This episode of What is Breast Cancer is going to deal with prevention and screening. For those of you who don't know me, my name is Donna Sidwell de Gracia. I have been a physician assistant for over 40 years and medical education for 20 years. I'm also a two-time breast cancer survivor. When I was first diagnosed, I realized that despite my years of experience, I didn't know very much about breast cancer and the patient experience. I had entered a whole new world at that time. Not long after that, some friends started coming to me who were also diagnosed with breast cancer with a lot of questions, and I realized that none of us really knew a whole lot about it. So that led to a series of interviews, a book, which you see pictured here, and then finally these little podcasts. So this is actually the third in the series, so be sure to look at some of the others. And the last episode kind of talked about what is breast cancer. It was very, very brief. We're going to go a little bit deeper today when we talk about prevention and screening. So, what are the types of prevention? In medicine, we typically divide prevention into three categories. In this episode, we'll talk about what those categories are and break them down. Always keep in mind that breast cancer is really a collection of diseases, and that even within one type, there are differences based on personal factors and other considerations. So prevention strategies may vary depending on those differences. Also keep in mind that categories of prevention used by medical professionals may not fit the usual definitions of prevention. So the categories are primary, secondary, and tertiary, and we'll go into each one of those. So first we have primary prevention. This is what most people equate with prevention. It focuses on trying to prevent the disease from occurring. Primary prevention focuses on risk factors and modifying those risk factors to decrease the chance of breast cancer developing. Breast cancer or risk factors are divided into two categories, modifiable and non-modifiable. So let's start with non-modifiable risk factors. This group is those things that you can't do anything about. So let's look at what they are. These are being female, growing older, and genetics. Genetic factors will go into, we'll get back to this in a few minutes, and then I'll have a whole nother episode on genetic screening. So we won't go into that now. But the image on this slide shows the difference between a normal cell and one that is missing the BRCA1 tumor suppression gene. Remember, we talked about Henrietta Lacks cancer cells continuing to divide and grow forever in the last presentation. The cell in the second panel is about to do the same thing because there's nothing to stop it. It's missing that suppression portion. So those are things we look at. We also look at reproductive history. We'll talk about this a little bit more when we talk about delaying child factor as a risk factor. The next one is your breast anatomy. So denser breasts tend to be more prone to breast cancer. And finally, previous radiation. Radiation therapy, especially to the chest, which, radiation is a common treatment for breast cancer. So that can be a risk factor as well. Kelly, one of the women I interviewed, she had another cancer. She had lymphoma at the age of 18. That cancer, plus the chest radiation that was used to treat that lymphoma, put her at higher risk for breast cancer, which she actually did develop at the age of 39. So those were non-modifiable. The next category is modifiable risk factors. So primary prevention really focuses on modifiable risk factors. These are the ones that we can do something about. The Center for Disease Control and Prevention lists these as sedentary lifestyle or not being physically active. Exercise is really good for you for a lot of different things, but and being sedentary is a risk factor for a lot of different diseases, including breast cancer. being overweight or obese after menopause. So these first two really have to do with diet and exercise. Many experts recommend 5 servings of fruits and vegetables daily. Think about it. A diet high in meat is suspect. Consider this. Many farm animals meant for meat are fed estrogens to increase their weight and make them grow rapidly. Some breast cancers actually grow better when they're fed by certain hormones, like estrogen. That doesn't mean everyone should be a vegan or a vegetarian, although those diets may be beneficial. What it does mean is that we should try to keep our meat consumption, especially processed meats, at a reasonable level. Exercise is good for everyone, so we won't go into that a whole lot, but it helps to control weight as well. It's also good for our mental and emotional health, not to mention sleep, and sleep is super important. Some experts think that stress may also be a risk factor for breast cancer and other diseases. So the exercise is not only good for reducing the weight and the ill effects of sedentary lifestyle, but also for our mental health. The next one is taking hormones. Hormones, they might be in the form of oral contraceptives or birth control measures, or the use of hormone treatment after menopause. We use them a lot during menopause for things like hot flashes and vaginal dryness, and they're really good for that. But the fact is that taking hormones may increase the risk of breast cancer. Decisions about whether or not to take hormones need to be a decision based on individual factors. Sometimes the benefits of hormone therapy may outweigh the risk. There has to be a lot of thought that goes into this decision. Over the decades, there's been a lot of controversy about hormones. But again, it has to be an individual decision. Some people are much lower risk for breast cancer and higher risk for other things where the hormones are helpful. Other people may be higher risk for hormones or for breast cancer and therefore probably shouldn't take hormones. So as we learn more about breast cancer types and how they're affected by the different hormones, we might be able to clear up some of those questions. For now, this should be a decision between the patient and the medical provider based on those individual factors and needs. Next one is delaying pregnancy. First pregnancy after the age of 30 may be a factor. Right now, a lot of women are delaying pregnancy for a variety of reasons. This is also an individual decision. It should be noted that delaying pregnancy is only one of many potential risk factors for breast cancer. The degree of increased risk is really not well known. So again, a lot of things have to be taken into consideration. In medicine, we always talk about the risk-benefit ratio. And if the benefit outweighs the risk, then it's probably something that you should do. If the risk outweighs the benefit, that will tip the scale in the opposite direction. Next one is alcohol consumption. Alcohol consumption is a risk factor for a number of diseases, including breast cancer. The usual recommendation for women should be to not consume more than an average of 1 alcoholic beverage per day. That's kind of being reviewed now, and it may actually be beneficial to do less. It doesn't really matter what type of alcohol, beer, wine, other forms of alcohol, all increase the risk. The next one that I put on here is not on the list that I mentioned, but that is smoking. Many list of risk factors list smoking as a potential risk factor. It's bad for everything. The bottom line is that primary prevention for breast cancer is living a healthy lifestyle. The one thing I would add about primary prevention has to do with genetics. Some people who have a known gene mutation, such as a BRCA mutation, may choose to have their breast removed. This is called a prophylactic mastectomy. And they might also have their ovaries removed to reduce the risk of developing cancers in those organs. There's also a lot of talk right now about a breast cancer immunization that hopefully will be on the horizon soon. We don't have a shot that will prevent breast cancer at this time, but stay tuned. It may be coming. The next category is secondary prevention. which many people think of as screening. The aim of secondary prevention is finding the disease before it causes any symptoms or lasting harm. If we discover a disease at this stage, we can try to either cure it or prevent it from progressing or spreading. Here, we haven't prevented the disease from occurring like in primary prevention, but we've slowed or prevented it from causing harm. I'll walk you through some of the screening tests for breast cancer. I'm not going to go through recommended screening schedules as they vary considerably based on a number of individual factors. I was asked a question on this in an interview recently and was told that my answer was very elaborate, and that's because there are so many different risk factors, and all of those have to be taken into consideration. So just as risk factors vary, so screening varies based on these. Medical providers will stratify patients based on personal risk factors and recommend optimal screening types and frequency. But we'll go through a few of the types of screening. The first one is exams, breast exams. These can be done by the patient themselves or by the provider. The breast exam can sometimes find a lump in the breast or an enlarged lymph node that might trigger additional screening. Breast exams, whether they're done by the patient or the medical provider, are non-invasive, so it doesn't require any needles, cutting, etc., and they're relatively painless. They sometimes reveal lumps that turn out to be treatable cancers. The downside of breast exams is actually twofold. Sometimes they miss lumps and may provide a false sense of security. So the patient might be convinced that everything's okay when it's really not. The flip side of that is that they may find lumps that are not cancer. Every breast lump has to be considered cancer until proven otherwise. What that means is that if a patient or provider finds a lump, it will need more evaluation, often a mammogram and a biopsy. The result of this is more worry, more expense, and possibly even scarring that will make screening more difficult in the future. Some experts do not recommend self-exams. Some providers do not even do clinical breast exams for the reasons mentioned above. I went through the breast exam in a separate video, so look at that, where I actually walk you through how you do a self-exam. I personally feel that they're a good thing because of the potential for finding a cancer early. I actually found my second breast cancer on self-exam. And I have had that experience with patients as well. The next thing we're going to talk about is mammograms. Mammograms are probably the most common screening modality used. For most women of average risk, yearly or biannual mammograms are recommended starting at age 40 or 45 and continuing through age 75. And the reason the numbers vary is because there are different guidelines by different organizations. So this, again, is pretty much an individual decision with the patient and their provider. So that scheduling might vary depending on which guidelines are used, updates to the guidelines, or, again, those personal factors. Many breast centers or state organizations offer resources for free mammograms for women who do not have insurance. You can see here in one of these pictures, there's the picture of the Mammo-A-Go-Go truck. This truck actually goes out to a lot of different organizations, including churches, and will often offer free mammograms for low-income women. The next thing we're going to talk about is biopsies. Most lumps are going to require a biopsy. Biopsies might be done under ultrasound guidance. They can be done with a needle or a small instrument that extracts a little tissue for evaluation. Or they might even remove a small lump if it's very tiny. Biopsies are done to confirm or to rule out the cancer diagnosis. So a mammogram can show the lesion, but it can't tell for sure if it's cancer or not. The biopsy actually takes some of that tissue, so it can be sent to the pathology lab. It can be examined microscopically to see if there's any cancer cells there or not. And then there's some other options. Other options can be used for some patients. I won't go through all of them here, but for a patient who is at high risk or someone who has particularly dense breasts, a mammogram might not be the best screening option. So there's ongoing work on making other options available and also on new screening modalities. There's there's research going on about a blood test to detect for cancer. Then, of course, if it is detected, further screening needs to be done. So all screening tests are meant to detect the cancer early while it is treatable and the patient has little or no symptoms. So what we're trying to do here is not prevent cancer itself, but prevent any kind of symptoms from the disease, prevent what we call in medicine morbidity and mortality. Morbidity being sickness and mortality being death. So the third type of prevention is what we call tertiary prevention in medicine. Most people don't think about tertiary prevention as prevention because it's not preventing a disease. It's rather an attempt to keep that disease at bay. Tertiary prevention is initiated when there is no cure. It is treatment meant to prolong and preserve life and to maintain optimal quality of life. So this is not a cure. This is trying to keep it under control. Breast cancer is a chronic disease. Once someone is diagnosed with breast cancer, they carry that diagnosis from then on. Tertiary prevention includes treatment to keep breast cancer under control. This usually occurs when the disease has spread or metastasized to other parts of the body. It also includes a whole team of providers to maintain physical function, to minimize emotional strain, to deal with side effects of treatment and disease side effects, as well as to improve the quality or at least maintain the quality of life that the patient has. So tertiary prevention might include things like counseling, yoga, physical therapy, music therapy, spiritual care, support groups, and other means of improving health and quality of life. Lisa, one of the people that I interviewed for my book, talked about tertiary care. She was diagnosed with stage 4 cancer. It had metastasized all over her body by the time she was diagnosed. She was on treatment to keep her cancer at bay as long as possible, even when she knew there was no cure. She also belonged to several support groups, including one for stage 4 breast cancer. The groups provided community and an opportunity for members to share their thoughts and experiences with people who understood because they were all going through end-stage cancer together. It's very important, particularly when you have metastasized cancer, to have people around you who understand what you're going through, people that you don't have to put a cheery face on for, and people who support you and actually make you feel good and make you laugh. Tertiary care can also help patients and their families with end-of-life care and decisions. Palliative care and hospice care are both part of tertiary care. They're a little bit different. Palliative care is comfort care, whether or not the patient and providers are working towards a cure. So palliative care does not necessarily start when there is no cure. It starts when the patient needs some sort of comfort care. Hospice, on the other hand, is care at the end of life when a cure is no longer an option. Hospice provides care and support for both the patient and their loved ones. Patients become eligible for hospice when their life expectancy is 6 months or less. And hospice care extends to the patient until death and to the family even after death. Many times patients do not opt for hospice care until it is very close to death, when actually there's so many benefits to hospice care and to keeping the family and the patient happy and with good quality of life and comfortable until the end. So that's the end of this little presentation. Next up is going to be genetic testing. If you have questions or you want to know more about me or my book, or simply follow my blog, my website is listed here, donnasidwelldegracia.com. And my email is accessible through the website, so please send me questions. You can now also add comments to this video. So thank you for your attention.